us, they have to tell us, what has worked among their friends. We do not ask them directly to start with, tell us about yourself. We usually say, what about your friends like you who have taken it up? What have they been experiencing? So I think this is the way to learn from them and then utilize that knowledge to devise a strategy so that we can help them to deal with tobacco. And of course, we all know that, it gives rise to many, many ailments, many ailments. Besides, young people also lose their youth, they lose their good skin, they lose their good hair. But in addition to that, I think it is very important for us to educate any public really after finding out what are the deficits in their knowledge and to tell them what are the diseases. Because, it's no use studying a 10-year-old that he will get cancer because it doesn't have much impact on that. But you cancer of the to the population who is likely to get cancer, middle-aged people, women, men, and so on and so forth. So I think we have to be very alert in what message we give and what position we take. And I will intervene in between if I have anything to say. Okay.
So thank you, Miraji. So Dr. Mira, I will let everybody know that Dr. Miraji is a behavioral scientist of international repute, and she's mentor to all of us actually in the tobacco control community. So thank you, Dr. Miraji, for your opening remarks actually.
Thank you for inviting me.
Yeah, thank you. So we'll wait for another 8 minutes and then start.
Okay.
Dr. Ravinder is with us. Ira with us. She's our host. Ira, are you with us?
Yes. Can you hear me?
Yeah. So you have gone through the slides, no? So you need to just introduce Rajiv ji.
Mm-hmm.
Yeah.
Okay.
And
Should
in
I share
between,
this right now?
but in between, whenever required, we'll just let you know, right?
Okay.
The main thing is that you have to see what is being done. Ira, you have to do a welcome address as well if Rajiv doesn't join in time, right? So you can see the agenda and you'll come to know about everybody there. Ira, are you listening?
Okay.
Yeah.
Yeah.
Okay. So just 4 minutes to go and then we'll start.
गुड मॉर्निंग सर डॉक्टर
गुड
गुप्ता सर गुड
मॉर्निंग। हाँ
मॉर्निंग
जी रविंदर जी, क्या हाल चाल है?
ठीक हूँ सर।
तो वो थोड़ा सा कुछ टेक्निकल इशू था तो इसलिए हमने ना 15 मिनट लेट किया, बट हम कोप अप कर लेंगे। तो विल स्टार्ट एग्जैक्टली एट टाइम। तो अभी मेरे को 2-3 मिनट बचे हैं, बस 3 मिनट्स हो गए, देन विल स्टार्ट। तो मीरा जी हमारे साथ है, उन्होंने अपना थोड़ा इंट्रोडक्टरी रिमार्क्स दे दिए, ओपनिंग रिमार्क्स।
गुड गुड मॉर्निंग मीरा मैम, गुड मॉर्निंग मैम, गुड मॉर्निंग चंद्रवंदना मैम। मैम आप म्यूट है मैम, म्यूट है मैम, आप म्यूट हैं।
Hi, Ravinder, seen you after a very long time.
यस मैम, यस मैम, यस मैम।
Welcome you to our group.
थैंक यू मैम। ना मैम ग्रुप में तो मैं हूँ मैम, मैं ग्रुप में
हाँ
हूँ।
नहीं, वो तो
और
मुझे पता है, तो लेकिन
हाँ,
मैंने
ये
देखा लेकिन
बोलते नहीं है ज्यादा, हम अगर हैं ग्रुप में हैं।
सर टीबी टबैको
हाँ
कोलैबोरेशन में इको का किया था ना, कुछ मंथ्स पहले किया था ना टीबी टबैको कोलैबोरेशन में।
हाँ, वो किया था हमने, हाँ जी। ये पिछले साल किया था इनफैक्ट।
जी सर।
राकेश रविंदर तो हमारे साथ बहुत पहले से काम करते थे,
आई नो, हाँ जी, हाँ जी।
बिफोर ही वेंट टू WHO।
डॉक्टर रविंदर और गोपाल ये इकट्ठे ही रहते थे हमेशा,
या राइट
मेरे को
राइट
याद है। हाँ, बिकॉज वी
राइट।
मेट, आई मेट देम टुगेदर इन अ
हाँ हाँ
मीटिंग। हाँ,
हाँ
जी
हाँ।
जी, अभी अभी भी हम इकट्ठे हैं सर, वी बोथ आर इन एनएचएम।
इन द सेम बोट।
या सेम बोट
या
सर।
एक्चुअली क्या है कि जो एक बार घुस जाए इसमें टोबैको कंट्रोल में, वो निकल नहीं पाता ना। किसी ना किसी
सर
तरह। हाँ
सर टबैको कंट्रोल में निकोटीन से ज्यादा एडिक्शन है सर। तो
हाँ।
सिगरेट में तो पता नहीं कितने एडिक्शन है, बट जो इस काम में है वो उनका फिर एक
हम्म,
अलग लेवल का
या अभी
दैट
आप
इज
मीरा जी को ही देख लीजिए। मीरा जी कितने, मैं कल 50 साल हो गए इनको तो, ऑलमोस्ट, या 45। कितने साल हो गए आपको टोबैको कंट्रोल में?
4 डेकेड तो हो ही गए हैं।
4 डेकेड तो हो गए, हाँ।
हाँ
और डॉक्टर राणा को भी काफी टाइम हो गया,
हाँ
ऑलमोस्ट मेरे 20 इयर्स होने वाले हैं, हो गए उनके। तो हम शुरू करते हैं। सो इरा, यू कैन स्टार्ट। या राजीव जी, आर यू विद अस?
Yes, sir, I'm here.
Okay, then Rajiv, she'll introduce you to all the participants and then we'll start. Right? Okay, Ira,
Yes, sure, sir.
you can introduce
Okay.
Rajiv ji. Yeah.
Good afternoon and a very warm welcome to everyone. I'm Ira Baga and I'm an intern at Sipher. Today, for World Tuberculosis Day, we are having our webinar on integrating tobacco and tuberculosis control programs in India. I'm honored to invite Dr. Rajiv Pradhan.
So I'll request all to please mute yourself. All others may please mute themselves. Okay. So Rajiv ji,
Yes, sir. I
ये मैं
request
म्यूट कर सकता सबको? अच्छा. ओह.
Sonal Smart, can you mute yourself, please? Thank you. So good afternoon, everyone, and warm welcome to all our esteemed speakers, experts, and participants who joining us today for this special webinar on observance of World TB Day 2025. So on behalf of Sipher, Resource Center for Tobacco Control, and Eco India, I extend a warm welcome to each one of you. So this is an important webinar on World TB Day. So each year, March 24th, remind us for a global fight against tuberculosis and a disease that continue to impact millions worldwide. So this year, under this theme, yes, we can end TB, commit, invest, and deliver. So we reframe our commitments to accelerate actions, fostering collaborations, and integrating innovative strategies to combat TB more effectively. So today we bring a focus on critical interactions in public health, the integration of tobacco control and tuberculosis program in India. So given the well-established link between tobacco use and TB, addressing these together is not just an necessary, but it's an opportunity for a win-win approach that strengthen disease prevention, treatment outcome, and overall public health. So we are honored to have with us a panel of renowned experts who have made a significant contribution in the field of TB control, tobacco cessations, and public health policies. So we have with us today Dr. Rana Singh, sir, Director Tobacco Control Southeast Asia Vital Strategy, who will deliver the keynote address. And we have with us Professor Dr. Ashok Bhardawaj, sir, Chairman National Task Force TB Elimination Program, who will share his valuable insight on the theme of today's webinar. And we have with us Dr. Ravinder Kumar, State Program Officer at TB Control, NHM Himachal Pradesh, who will introduce with the new shorter oral regimen for the treatment of MDR TB. We have with us Dr. Puneet, Technical Advisor, Tobacco Cessations, Vital Strategy, who will highlight the importance of TB and tobacco integration in India. So we also thank Dr. Sanchika Gupta from Eco India for providing a platform and support during this event. So with this, let's begin our insightful discussion. And now I invite Dr. Rakesh Gupta, President and Sipher, to provide an overview on World TB Day 2025 and its significance. So over to you, sir, for your address. Dr. Rakesh Gupta, sir.
So we have very stalwarts with us who will tell us about why the World Tuberculosis Day is celebrated. And the theme for this World Tuberculosis Day is yes, we can end TB, commit, invest, deliver. And we have with us very eminent personalities like Dr. Ashok Bhardawaj, Dr. Rana Singh, Dr. Ravinder, and Dr. Puneet, who will be telling us about different issues and why TB tobacco collaboration is required. So over to Dr. Rana for his opening remarks, actually. So Dr. Rana Singh, as Rajiv has already told you, that Dr. Rana Singh is with Vital Strategies these days, and he's Director Tobacco Control Southeast Asia, Vital Strategies. So over to Dr. Rana. Thank you.
So thank you, sir. Please give me access to share my screen.
Okay. Okay. First, I'll stop share, and then I'll allow you. So you are allowed, sir.
Okay. Is
Yes,
it
your screen.
visible?
Yeah, it is visible.
Yes, sir.
Thank you.
Okay. So thank you very much. Apologies if there is some problem with the internet because I am on duty travel. So, uh, so thank you once again, and it's great to speak on a subject after many years about tuberculosis control and how it is crucial, why it is crucial that we have. There are coordinated efforts are required uh, for control of both major public
Yes,
health,
yes, yes.
both major public health challenges.
You've been muted by mistake. Yeah. So can you unmute yourself?
Yes. So, respected
Okay.
Professor Ashok Bhardawaj, Chairman National Task Force of
Sufficient cotton.
National TB Elimination Program, our mentor and guide, Dr. Mira Aghi, my colleague, Dr. Puneet, team of Sipher and Resource Center for Tobacco Control, Mr. Jeev and colleagues, and all the participants. First of all, thanks to Sipher and ECO and Resource Center for organizing this webinar very timely. And I think already, the theme of this year's World No Tobacco Day, World TB Day has already been shared by Mr. Rajiv. So theme is yes, we can end TB, commit, invest, and deliver. So it's important just to understand what is the latest TB burden. So still we are seeing deadliest infectious disease. It continues to devastate millions of people globally, inflicting health, social, and economic consequences. And as on 2023, almost 11 million people fell ill with TB in 2023, which means incidents, new cases. So this is a huge burden if we
Yeah,
look
yeah,
at
yeah.
the new cases which come every year globally, and it continues to kill people. So almost 1.25 million people died of TB in 2023. So still, it's a huge burden. After you can say discovery of first anti-TB drugs like streptomycin, and thereafter many other treatment options which were available to us. This year is a theme uh, which uh, which uh, which shows that we can end TB. So basically, what is the purpose of this theme? It's a call for action and accountability to accelerate efforts towards uh, ending global TB epidemic. This theme, if you see, it offers an opportunity to reflect on ongoing efforts. What are the efforts which are already uh, there? And it is also encouraging stronger commitment at local, national, and apology, and encourage stronger commitments at local, national, and international level to end TB, including by combating the growing threat of drug resistance TB. So what does this means, all of that? What is commit? So you see, recently in 2023, we had a summit, world leaders high-level UN high-level meeting, where it pledged to accelerate efforts to end TB. And now we need real actions. And what are those actions?
Doctor,
Sir, apologies. Suddenly, I'm not aware what happened.
no,
So
it's okay. Okay.
now we need real action. So what does this commit really means? First of all, we all need to commit rapid implementation of WHO guidelines, guidance, and policies for TB control. We need to strengthen national strategies. I will share what India has done for that. And then we should also commit full funding, whatever the funds we require for TB control globally and in our respective countries. So this is a commitment which should come from highest levels in politico-administrative leadership. So this is about commit. What are the things which we need to do? First of all, we need to commit that we will implement WHO guidelines and policies for TB control. Further, if there are some gaps, challenges, we need to strengthen national strategies, and countries should commit that they will fund for TB control. Then second part is invest. So we all know funds are required for everything. So TB cannot be defeated without proper financing. It is currently it is underfunded. The amount of funds which are required for TB control globally and in respective countries. So it is underfunded. We need a bold, diversified approach to fund innovations, to close gaps in access to TB prevention, treatment, and care. And third part is very, very important, very, very crucial to advance research and innovations. So for that, we need to invest in all these areas. And fourth part is deliver. So here we need to turn our commitments into action. That whatever we have committed, that needs to be converted into activities and actions, and we need to scale up proven WHO recommended interventions for early detection, diagnosis, and prevention of treatment. And I hope Dr. Ravinder ji, apologies, I missed him. So I think Dr. Ravinder, he will share with us in detail. I would request him that just give a brief snapshot of the current status when he make his presentation. Second is focus on high quality TB care, particularly for drug resistance TB. And third, success, it depends on community leadership. So it's not only the government agencies, but community leadership, civil society action, and cross-sector collaboration. So these are very, very crucial. So when we talk of deliver part of World No Tobacco Day theme. So these are the things which have been emphasized. So there is emphasis should be placed on these aspects of delivery for TB care services. Yes, we can do. It's really the theme. Really is a bold call for hope. So this theme is a which gives us hope, urgency. It also gives us a feeling that we need to have, we need to show and act it as an urgent matter, and accountability. Accountability is very, very important. So whatever we have decided, whatever we have committed, we are accountable to do that. So these are this is the way how I look at and we look at this World No Tobacco Day theme. Now, very quickly, I want to be going into detail. So what India has done? What is the India situation? So we know India has highest incidence globally. 26% of all incidence cases. So this is again very, very important to keep in mind that 26% of all incidence cases globally, India is accountable. Then TB deaths, yes, if you ask me what is the change in last, for example, more than 2 decades, we know first we had RNTCP, Revised National TB Control Program, and now the program has been renamed as NTEP, Immunization Program. So TB deaths has definitely decreased from 580,000, means 5.8 lakh in 2010 to 320,000 in 2023. And yes, many steps have been taken. So important step was in launch of National Strategic Plan in 2017, which we call as 2017-25, to bring a complete transformation. So this strategic action plan, strategic plan, you can
रोल
say
था जिसको
it was
जाना सकता है,
it,
मतलब
it,
जो
it
टाइम है उसका हिसाब से इधर का सब हो गया है। मैम ने ऐसा कॉल किया मेरे को, काम सब
please
हो
mute,
गया है खत्म। अब
please
जिसका
mute,
जो टाइम पे जाने
rather
का है वो जा सकता है।
please
लेट
mute,
मी गो
Navyas,
तो इधर
please
सब हो
please
गया
mute
है,
yourself.
ऐसा वर्ड बोला मैंने।
please mute.
मैं जा रही हूँ, क्या पूछो फोन अभी फ्री है मैम, पूछो बाय बाय।
Okay,
Radha,
I'll mute it up.
so India launched this national strategic plan. So this is something which gives us complete guidance, and it really gave us those strategies to prevent TB, detect TB, and treat TB. So very crucial for the country to see that if this action plan is strategic plan is with us, we are able to implement that strategic plan. Then many important steps to decentralize TB. Many other players have been involved. Ayushman Arogya Mandir has been involved. Private sector. So there is big engagement of private sector. So this was big change. If I was also part of TB control program way back, so engaging private sector that was a big change, and happy to share that almost 8 to 9 lakh TB cases have been identified through private sector engagement alone. So I think this is a big contribution of private sector involvement. And then finally, the call by Prime Minister, Honourable Prime Minister, TB Mukt Bharat Abhiyan. So this is again something which gave a big impetus to the TB control efforts in the country. And more than 1.5 lakh individual and organizations, they have come forward. I'm saying not engaged, rather they have come forward to support India's TB control efforts. So this is very quickly. I hope Dr. Ravinder ji and finally our chair of today's webinar, Dr. Ashok Bhardawaj ji, they will provide us the more detail and what we need to do. Then we have another session on TB tobacco integration. We all know that 40% of TB deaths they are because of tobacco use among TB patients. So already Government of India has launched a joint TB tobacco collaborative framework for integration of TB and tobacco control program. Every TB patient, we must ask history of tobacco use and provide counseling to quit tobacco in TB patients. So if you ask me what is the implementation, it's variable across the country. It's variable across the country. Few states are doing some good work. I would request later on after Dr. Puneet Chahar, I would request again Dr. Ravinder, what efforts, if we can briefly share. So what efforts have been made on integration of TB and tobacco control in the country, and other comorbidities are also very crucial, which includes definitely HIV/AIDS and diabetes mellitus, which are at least, there are many other, but these three, that is diabetes, then HIV/AIDS, and then TB, tobacco use. So these are the three major comorbidities which are very crucial. So we need to work and collaborate and integrate all those programs, public health programs together to achieve our and TB goal in our country and globally, including globally. So thank you very much. So this was very, very brief. Just to share with you the theme of World No Tobacco Day, what are situation globally, and in just in one slide, what India has been doing. So thank you very much, and over to Dr. Rakesh Gupta ji and Mr. Rajiv.
So thank you, Dr. Rana, for giving us a brief about the World TB Day, and you have summarized it in a single line, that bold call for hope, urgency, and accountability. So we'll just have questions from the audiences, then get back to you. So I think Dr. Bhardawaj has joined us. So Dr. Bhardawaj, are you with us, sir? Dr. Bhardawaj? So Dr. Bhardawaj, are you with us? Actually, I can see him joining, but I don't know why he's not responding. Dr. Ashok Bhardawaj, are you with us?
Just join, sir, again. I think I've
Okay,
seen
okay.
sir join.
Please unmute yourself, sir. Dr. Ashok, please unmute yourself.
Yes, I am unmuted.
Okay, okay. Thank you. So we have with us Professor Dr. Ashok Bhardawaj. He's chairperson of National Task Force on NTEP, and he's Professor Emeritus at Medical College and Hospital, Solan, Himachal Pradesh. And he has worked as Professor Community Medicine in medical colleges of Shimla. So over to you, sir.
So thank you, Rakesh ji, thank you. So am I audible?
Yeah, you are audible, sir.
Yeah, so thank you for giving me a chance. So it was my proud pleasure to be involved in this. So we know that day after tomorrow is the World TB Day. So the theme this year, because this year is very important for our country, because our Prime Minister has committed that in 2018 that we will make India TB free by 2025. So this is March, and 2025 means December 2025. So the theme this year is the commit, invest, and deliver. So I'll like to share my views in this, that if we have to end TB from the country. It does not mean eliminating TB from the country, because elimination is a distant dream. So elimination is possible when you have got one case or less than one case per million population per year. So it's not possible. The global target for elimination is 2050, but in our country, I think it is still a distant dream. So what we are vying, it is the ending TB from the country or making India TB free, where the globally there were three indicators to reduce the incidence by 80% as compared to 2015 baseline, and to reduce the mortality by 90%, and to make the catastrophic expenditure by 2025 to zero. Still, people are spending a lot of money from their pocket for the management of tuberculosis, whether it is buying medicine, whether it is buying the diagnostics, or the sequelae after the treatment of tuberculosis. because there are many cases. There is fibrosis in the lung, which patient go for treatment for the surgery, etc. So, if we have to achieve this, because the still within 9 years we were not have much progress, because the progress in all these three indicators is 18 to 20%. So for me, if we have to end TV from the country, so I have got only four possibilities. The first possibility for any disease to eradicate it, to eliminate it, to end it is the vaccine, the availability of safe and potent vaccine. So we still don't have any vaccination against tuberculosis. 1993, the TB was declared international emergency, but still more than 30 years down the line, we were not able to develop any potent vaccine against tuberculosis. There are many candidates, some succeeded, some are under trial, but we don't hope that this year at least we will get any vaccine. Maybe next year, as per the competent authorities, we may get one candidate vaccine against tuberculosis. So, vaccine we don't have. Second is the TB preventive treatment, means prevent new infection. We are treating the patient, we are diagnosing the patient, but if we do not prevent the further infection, the new infection, the cases will go on occurring. So we have to prevent new infection by TB preventive treatment to the household contact of TB patient, to the occupational contact of TB patient, and to all vulnerable population which have got more chances of developing tuberculosis. So still our progress in the country is not more than 40%. And we know that by mathematical model, if we do not saturate the country by more than 95% for TPT, we will not be able to go anywhere. So TPT is very important. Third is the notifying all cases, because I belong to medical college. I am looking after a medical college in the country. So notification by some department, this it is negligible. Till each department take keen interest and refer patient for TB screening, then we will be able to find the missing cases and put them on management. So notification in each department is very, very important. Last is to find more presumptive TB cases, because we know that during survey of 2019-2021, 42% of the cases diagnosed as pulmonary TB did not had any sign and symptom. Now, where to find these cases? Because it is said that the tertiary institution, including medical colleges, at least 10% OPD referral should be there for TB screening. But pan country, I have visited 207 medical colleges. The average is only less than 1%. We are not referring the patients for screening of tuberculosis. There is we are admitting the patient, but there is no uniform indoor screening. We are having diabetic clinic in big institution, but all diabetic patients they are not screened for tuberculosis. So these four possibility, if we work dedicatedly toward this, there is no chance that we will end TB. We will end TB from the country, or we will be near to it if we dedicatedly follow all these practices. So I always say commit, invest, and deliver. And support TB patient if you have means, and become Niksha Mitra, because nutrition is the main driver of epidemic in our country. Many cases are attributed to malnutrition. So if we support the patient by psychosocial support, by nutritional support, then we will say that we have achieved our objective of coming to this world. So thank you, Rakesh ji. Thank you for giving me a chance.
So
टीवी
thank you,
हारेगा
Dr.
देश
Bhardawaj.
जीतेगा टीवी
Yeah.
हारेगा देश जीतेगा
Thanks a lot for your crisp message. And I think rightly said that a potent vaccine has not been developed in 30 years, and we'll need a potent vaccine, so that we can end tuberculosis. And also, we have to make it a it is already a notifiable disease, but we have to strict to it that all the departments, they notify the disease, and all the patients, they are referred. So 10% referral is required, and as you say that only 1% patients, they are referred for screening of the tuberculosis. So thanks a lot, sir. Sir, if you can stay with us, we may have questions for you, sir.
Okay, I will there. I'm there.
Okay, thank you. So now we have with us Dr. Ravinder from Shimla. So he'll be telling us about the short treatment for tuberculosis, which is now in place. So it is a 6-month regimen. So Dr. Ravinder is State Program Officer for National Tuberculosis Elimination Program of Himachal Pradesh, and he's currently his prior position was he worked as WHO consultant for tuberculosis program in Himachal Pradesh. Also worked as technical officer tobacco control in the union from 2015. 2012 to 2015. So over to Dr. Ravinder. So Dr. Ravinder, I'll share your screen. So yeah, so you can start with your presentation, sir.
Thank you, sir. Thank you so much. I'm very grateful to Sipher team and the organizer to give me this opportunity. This is a new regimen, sir. So those who all work for TB and also for public health, I mean, this is a good news for at least in the TB world. This regimen is BPaLM regimen. So I will be discussing about this. Currently, the guidelines which we are following is 2021 guidelines, which is known as Guidelines for Programmatic Management of Drug-Resistant TB in India. New guideline is just released in the month of December and January. Next, please. So here is the new guidelines. So up till now, next please. Up till now, we were giving this 18 to 20 months regimen for MDR and XDR TB. Every day, patient has to take this much of pills. So for complete course of 18 months, each MDR and XDR patients, pre-XDR and XDR patients, they used to take about 14,000 pills. And prior to that, in the previous regimen, 180 to 240 injections were also there, but at least no injection are there since 2021. Now this new regimen, it will have less than 750 pills for entire course of 6 months. So this is the new. Next, please. So just one small box of BPAL. Next, please. So these are the drugs for entire course of MDR and XDR TB patients for 6 months. Next, please. So as we know that about 7% of TB cases at any given point of time, they are drug-resistant TB. So they are a basic 4 drug, which we call as a first-line drug. That is HRZD, isoniazid, rifampicin, pyrazinamide, and ethambutol. So if a patient is resistant to isoniazid, the patient is known as mono-HDR TB. If patient is resistant to rifampicin, the patient is known as RIF-resistant TB. If patient is resistant to both INH and rifampicin, then we call it MDR TB. And MDR TB patient, if he is resistant to fluoroquinolone, then we call it pre-XDR TB. And that pre-XDR TB patient, if he is resistant to linezolid or bedaquiline or both, then we call it the XDR TB. And in India, all types of these TB patients, they are found. Next, please. So these are 4 tests to diagnose drug-resistant TB. The 3 tests, CBNet, TrueNet, and LineProbe assay, they are basically genotypic test. And solid culture and liquid culture, they are known as the phenotypic test. And every state is having these technology. So we in Himachal have all these technology. But I'm saying every state is having these technology well placed in, by the program. Next, please. So this is the diagnostic algorithm, which is actually changed, and this is very new diagnostic algorithm. Here, if we see that, so this is integrated diagnostic and treatment algorithm. we take two samples from each TB case, whether we want to diagnose RRTB or there is a case which is having abnormal X-ray or there are some cases which are non-responder to the primary drug. Then, if we get the result as a MTB positive in a CB-NAT and we get the result as R resistance detected, then we see how old is the patient. If patient is more than 14-year-old, in that case, we see the eligibility criteria of that patient toward this new regimen BPaLM. And if this patient is eligible, then we go ahead with the BPaLM regimen. But if the age is less than 14, then BPAL regimen, it is not, as of now, applicable for the child patient of age less than 14 years. For that, the shorter regimen of 9 to 11 months, that will be given. But if the patient is not eligible for even that 9 to 11 months regimen, then patient is put on existing longer regimen, that is 18 to 20 months. And if we see on the right leg, if we got MTB positive but R resistance is not detected, in that case, we give that simple drug sensitivity treatment, that is 6 months, 2 plus 4 months DSTB, FDC basically. And then we test for line probe assay. If H resistance is detected, then we
Dr. Ravinder, I have actually uh, by
Can I share
mistake.
myself? Can I share myself with
नहीं
you?
नहीं 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 मैं करता हूँ अभी एक सेकंड. Yeah, is it all right?
Yes, sir, it is all right.
Oh,
It is all
okay.
right.
Thank you.
So if we see on the right side, we do first line LPA. If H resistance is detected, then we give the mono H regimen. But if H resistance is not detected, then we give the same DSTB treatment of 6 months. Right. So the new thing is here is for a MDR and XDR TB patient, if their age is more than 14 years, then this new BPAL regimen is there. Please click, sir. Next, please. Okay. 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 This I have covered. This is the same thing. Next, please. Next, please. This is same. Okay. So what is this BPAL regimen? In this BPAL regimen, we have bedaquiline, we have pretonomid, we have linezolid, we have moxifloxacin. Although under the program, we were using bedaquiline, linezolid, and moxifloxacin say for past 3-4 years. But now this pretonomid new molecule, it is their new weapon basically for TB patients. Now in a combination, this new regimen is made. And this BPAL regimen for last 2 to 3 years, it was there in implementation research globally in few countries. And then past 2 years, it was there in India. Very good result were obtained with this BPAL regimen. And now it is under the program condition. Next, please. Next, please. Next. So, who are the patient to whom this BPAL regimen can be given? Person with age more than 14 years and new microbiologically confirmed MDR RTB. If some people have exposure to bedaquiline, linezolid, or pretonomid in the past, but it should be less than 1 month. And if have exposure to more than 1 month, then sensitivity has to be documented. Because these drugs, they are basically, they cause cardiac arrhythmia also. In that case, ECG is very, very important. So this QTCF interval in ECG, it should be less than 450 millisecond in males and less than 470 millisecond in the females. Only then we can give this BPAL regimen to these patients. And also in among women, to the non-lactating women, lactating and not breastfeeding, non-pregnant or pregnant women with less than 20 or 24 weeks of gestation period. Otherwise, we cannot give this to the pregnant women. And the exclusion criteria is just opposite of this. To the kids, we are not giving this. As of now, we don't have the practical experience in the field, so that is why we are not giving it. But right now, to the patients of age more than 14 years, and if we see the disease epidemiology in the field, we are not having that much number of DRTB among children. Mostly, mostly adolescents and then adults and then old age. Next, please.
Is it visible?
Yes, sir. Next slide, sir. Thank you.
Okay. This one?
Okay. Yeah. So how
Okay.
much is this duration? It is 6 months. For some cases, it can go up to 9 months. But it's just 26 month treatment. So Bedaquiline, for the first 2 weeks, we give it 400 milligram once daily, and then next third to 26 months, we give it 200 milligram 3 times in a week. Ritonamide, we give it on daily basis, 200 milligram. Then linezolid, we give it 600 milligram once daily, and then moxifloxacin, 400 milligram once daily. And because the side effect of especially the linezolid medicine is peripheral neuropathy. And to avoid this peripheral neuropathy, the pyridoxine tablet is always added. Next, please. So pyridoxine, we give 1500 milligram once daily for weight band of 16 to 29 kg, and 100 milligram for a patient having weight of more than 30 kg. Next, please. So not only for BPaLM regimen, but for all drug-resistant TB cases, whatever medicine we give, intensive follow-up activities has to be done. Otherwise, these DRTB drugs, they are having very, very high side effects. And if these side effects, they are not, you know, identified on time, the requisite tests are not done, and some actions are not taken, we can lose the patient also. For that matter, if I, put some patient on BPaLM regimen, clinical follow-up is very, very important every month. We have to do CBC, hemoglobin and platelets count is must, and ECG day 15 and 30. Why I'm saying so? Linezolid is a medicine which can cause hemolytic anemia, and because of that, suddenly the hemoglobin goes down, and in that case again we can lose the patient. So very, very important that this has to be done. Visual acuity, color vision, that is again needed. Smear microscopy we are also doing with culture examination. Second month onward, we need to take the sputum sample, and it has to be sent to the IRL laboratory, and where these culture tests are done. And whether to extend the treatment or not to extend, it depends upon the results of the culture. Next, please. DST. So, although we are giving these drugs, bedaquiline, pretonamate, linezolid, moxifloxacin. So whether these drugs are also working or not working, for that also DST is done. So first we do the liquid culture, we get the growth, and on which we do the DST. Of course, the urine pregnancy test, it is actually to be done among the married women of the childbearing age group. Because and we always say not to go for pregnancy family planning, because during this period, if they because it interferes basically. And we also don't give the hormonal based contraceptives. So best is the barrier method. Chest X-rays, it is also done frequently. Serum electrolyte is very, very important because it actually causes QTCF prolongation. And in that case, we have to deal with if there is some dearrangement of the serum electrolytes. Specialist opinion are also often taken, and long-term follow-up is also done. It is also done periodically. Sir, can you go to at least 4 or 5 slides back, because one slide is missed, and that is actually important. Uh, yes, back, back. बस सर यहीं पे thank you.
Okay.
So now, what is there in India, how TB patients are basically they are treated. Say if we are having 100 TB patients, for 90, more than 90 patients, we are giving them 6 months drug sensitive TB, that is HRZD. But about 10% of TB patients, yeah, say if you say 10 to 15% of TB patients, they are drug resistant TB. For them, that DSTB of 6 months regimen does not work. For them, there are regimen for drug resistant TB. So if person is resistant to H, that is INH, then we give them 6 months mono H DRTB regimen. That is existing. We are giving this for last 3 years. If patient is resistant to MDR or RR, we are giving them 9 to 11 months regimen for last 3-4 years. if patient is resistant to MDR plus fluoroquinolones and plus say linezolid, we were giving them 18 to 20 months. Now what we are going to do with this BPAL regimen, the patient belonging to serial number 2 and 3, these regimen, they will be now given as per priority number 2 and 3 only. Maximum patient, about 80% patients, they will be put now on BPAL regimen, which I discussed in this session. And what is the current status as on today in the country? Haryana has started this, I think, 1 month back. UP has also started little bit. Tamil Nadu and Karnataka also. And in Himachal, we are going to start it just day after tomorrow. That is on 24th March 2025 on World TB Day. Yesterday only we have got this medicine in our state drugstore. And now we are giving this drug to the field. And so, what change it will bring in the life of MDR patients? This patient will not take medicine for 1.5 years. He will finish this, take medicine for 6 months only. So, the treatment outcome of DRTB in the country, which is about 60 to 70%, we expect this will go more than 80 or 85%. So, less doses, less pills, less side effects, better outcome, and win-win situation for the program manager as well as to the patients. This is all there from my side, sir. Thank you.
Okay, thank you, Dr. Ravinder, for summarizing the new regimen, which is quite shorter. It is about 6 to 9 months, that BPALM and BPAL. And earlier we had to give 9 to 11 months shorter treatment for MDR and RRTB cases. And it is very heartening to note that UP, Haryana, Tamil Nadu, Karnataka, they have already started this regimen, and HP is going to start very soon on 24th. So please stay with us for questions from the audiences. So thank you, Dr. Ravinder. So we have with us Dr. Puneet Chahar, who is Technical Advisor Cessation, Tobacco Control in the Vital Strategies, and he's current providing support to MHFW in implementation of Management Information System and feedback to the states to strengthen the monitoring and evaluation framework and activities under the NTCP. He worked as a clinical research officer, Safdarjung Hospital, Delhi in WHO project. So we'll be listening to him about the importance of TB tobacco integration towards control of tuberculosis and tobacco use in India. So over to Dr. Puneet, please.
Thank you, Dr. Rakesh. Can I share the presentation from my side?
Yes, you can do that.
Yeah, thank you so much.
Okay.
Greetings to colleagues and seniors, Dr. Ravinder, Dr. Rana, Dr. Ashok, and Dr. Mira also. Thank you everybody for joining, and I'll keep my presentation really brief. Okay. Is my slide visible?
Yeah, it is visible.
Okay,
so I'll make it slide. Yeah, it is done. Okay,
thank you so much. So I think many of the previous experts have already told about the theme, for World No Tobacco Day. It's commit, invest, and deliver. And I think all the three terms are, are in context with tobacco control also, because if we want to achieve an end tuberculosis by 2025 for India that we expect, and also 2030 as per WHO, I think investing and delivering focused tobacco cessation intervention within the realm of tobacco control is also very important. These are the contents, and one by one I'll go to each. So if we see this figure, we can see that tuberculosis and tobacco epidemic are both public health culprits. When we see tobacco epidemic, India ranks number 2 for consumption. Tuberculosis, India ranks number 1 for TB cases. Almost, 9 crore smokers in India and 20 crore smokeless tobacco users. And the burden of TB, Dr. Rana has already, told. Almost 2.6 million TB people, people were infected in 2019. And relatively, if we see the recent annual TB reports also, the number fluctuates around this only. However, if we see, the total number of TB patients who are consuming tobacco in annual TB reports, we see only 11%. However, if we see the other research shows, use of tobacco among TB patient as high as 40 to 50%. So tuberculosis and tobacco, I think previously also it has been discussed that there are certain risk factors or comorbidities for TB, and we often talk about malnutrition, diabetes, HIV, alcohol. But I think usage of tobacco and smoking is also very important risk factor. And if you see global TB report 2022 says that almost in between zero point 0.5 to 1 million TB notified cases are attributable to tobacco slash smoking. When we talk about India, I think India is a country which is in contrast to Western, pattern of tobacco use, where smoking is more prevalent and maybe sometimes only form of tobacco that is being used. But when it comes to India, it's smokeless tobacco followed by smoking and dual use. So as I already told, almost 20 crore tobacco, SLT users and almost 10 crore smokers that are there, and out of these 10 crore smokers, 70 to 80% are using a form of smoking, which is known as BD smoking. So within this context, if you see, I think there is a disruptive convergence that we see when we talk about TB and tobacco, and they meet at some point of time. You can see from this figure, I think wonderfully, it says that when we talk about smoking or any biomass fuel, tuberculosis, the risk of latent infection is increased. The progression to active disease is increased. Mortality from TB is increased, and even let me tell you, TB treatment outcomes are also complicated, and there are higher chances of complicated TBs that may be there if the person keeps on smoking. So I will one by one talk about different form of evidence that is present when we talk about tobacco smoking and TB. So different meta-analysis have shown that when a person is a smoker, the chances of TB infection is 6 times as compared to non-smoker. Having a TB disease, it is almost 15 times. Pooled relative risk is 15 times as compared to non-smokers, and mortality is also 5 times. So these are stark evidence that says that we need to invest in tobacco control also, and the TB community and those who are trying to eliminate TB should also be a think tank, or propellers to advocate for tobacco control also. When we talk about passive smoking, it's not that only active or first-hand smoking is responsible for TB. Even studies have shown that whenever there is a passive exposure to second-hand smoke in the household, it is independently associated with culture-confirmed TBs. And it's also a risk to the children also who are there in the house if somebody is smoking. And studies have shown that there is an increased risk of latent TB infection almost 1.64 times, and active TB infection almost 3.4 times in children, and with active TB in adults. So children are also at higher risk in homes where people are smoking. When we talk about TB treatment outcome, I think I've already told that, and data also says that almost 16.7% of unsuccessful treatment outcome are attributable to smoking. So these are this basically further exemplify that whenever a person is a smoker, there are higher chances that there will be a complication with the TB treatment as well. Similarly, smokers are significantly associated with increased risk of recurrent TB, and also risk is double in smokers who smokes greater than 10 cigarettes per day. Also, there have been studies which have showed that there are longer delays are significantly associated with current smokers, and also risk of transmission of TB to the community is higher and there are higher increased care costs, because when you have complicated TVs and relapse because of tobacco smoking, the burden ultimately falls on to the health facilities and healthcare system. And one more thing that we don't often talk about is SLT, use of SLT and TB relation. And I think there have been few studies which have shown that, for example, this if you see this figure, you can see the prevalence of SLT use among TB in various states is almost ranging from 20 to 30%. However, reduced in less than 10% in few states. So there is a existing evidence that even SLT can directly or indirectly lead to higher incidence of tuberculosis. And if you see the last line, SLT use is linked with decreased immunity and thus indirectly may be a risk factor for TB infection as well. And if you see in smokeless tobacco, there have been studies, which have shown that there are bacterial contaminations. There are aerobic bacteria that have been found, and if I'm not wrong, Mycobacterium is also an aerobe, and there are high chances if we look. There have been no studies still, but I feel if we look for such bacteria, I think they may be present in smokeless tobacco as well. I already have talked about economic burden. So when you are a smoker or SLT user and there are high chances of relapse, complicated TB outcomes, the burden ultimately falls onto the healthcare system to treat one patient at multiple times and investing in that patient so that he gets well. Now, the question comes, can we eliminate TB without tobacco control? And I think we all know the answer to it. It's a no. And if we want to eliminate TB within that stipulated, time that we have, kept for ourselves, and even Dr. Ashok was also talking about it, that we have to look at other determinants or other risk factors also if we want to make, eliminating TB a reality. What is the need for tobacco control when we talk about TB? I think almost 12% of 1.4 billion people are at risk of developing TB infection in India. And if smoking and smoking is also increasing, then you can expect that there will be higher chances of TB infections as well. Now, what the Ministry of Health have done after since 2015 or 16, I think there have been 2 consecutive workshops, and ultimate result was national framework for joint TB tobacco collaborative activities. And I think this is a wonderful guideline which guides the states to implement joint TB tobacco collaborative activities. But implementation remains a challenge, and I think Dr. is there, Dr. Ravinder is there, and I think I would also invite him later on to please, share his experiences also when we talk about implementing this guide. And within the guide, I think if you ask me, there have been multiple roles and responsibility that have been defined for NTCP as well as NTEP also at state level, at district level. However, I feel that the most important domain where a TB patient who is reporting to a health facility who can be provided a tobacco control intervention is tobacco cessation, or Article 14 of WHO FCTC. Tobacco cessation under NTCP is an important thrust area, but if we see the current structure or ecosystem of tobacco cessation in India, I think we do have tobacco cessation centers at district level. But when we talk about district having these TCCs at district hospitals, sometimes it becomes a challenge, with respect to accessibility also for a patient who is away 30 to 50 kilometers and has been diagnosed with TB. So there have been multiple approaches for providing brief advice to these TB patients who are sometimes, motivated to quit because they are, experiencing that kind of disease, and complications because of TB, and they already have been, told about that this may be also because of tobacco. So I would request, can we mute?
Vishnu Kumari, please mute yourself, please.
टाइम लाग्छ होला नि कति बजे आइपुग्छ कति बजे छुट्टी हो
Rakesh sir, can you?
अघि 1 बजी उले जी ट्युसन पढ्ने रहेछ नि ल्याइदिन्छु भनेको थियो नि त
Okay. Okay. When we talk about cessation outcomes in TB patients, let me tell you, cessation rates of 57.8% have been achieved only with brief counseling at a tobacco cessation center, and with pharmacotherapy, the cessation rates have increased to 78% by one of the study at Maulana Azad, Institute of Dental Sciences. And also from Indonesia, also we have seen a greater number of patients being quitting. So if you see for cessation statistics in India, and if you see annual TB report, it says on only 32% patients were ultimately linked for tobacco use to a cessation center, and I think this number has been relatively same for last 3 to 4 years, and I think we need to increase this number at least so that TB patients are more and more TB patients are referred to tobacco cessation services. So when I talk about tobacco cessation services, I'm not only talking about tobacco cessation centers, but I'm also talking about other digital interventions or population level interventions that already exist. But sometimes while visiting the field also, I could see that the TB workers, TB health visitors, or even the medical officers are only are aware about the tobacco cessation centers that are there in the districts, not about these services where patients can also be referred if patient is not able to visit during that time to a tobacco cessation center because of the distance. So this is the information that was put in TB treatment card. So you have 3-4 indicators. Are you a current tobacco user? If yes, you have to mark for the patient if the patient is smoker or smokeless tobacco user, and linking the patient for cessation. So at the end of the treatment, if the patient has not quit, then you link the patient to a tobacco cessation facility or tobacco cessation services. However, during the time at whatever number of times the patient comes in contact to a TB worker, he should be provided a brief advice that is also being written in this guide. However, the challenge is if the brief advice is being provided, it is not recorded in the TB treatment card. So, and also, if the tobacco user has quit the habit, you have to mark quit or not quit. But within the annual TB report, we don't see, data for status of tobacco use at the end of the treatment, whether the patient had quit or not quit. So recently, I was there in a facility in Uttar Pradesh. It was a PHC and also or Arogya Mandir Health and Wellness Center. And you could see this was a recent case. I could see the format, and you see only information about tobacco user have been marked here, but there have been no detail whether the patient was smoker or smokeless tobacco user, and whether the patient was linked for tobacco cessation, or whether the patient was provided brief advice. So I think these are the opportunity, because in the upcoming 6 months or 4 months, the patient will be coming in contact with the TB worker, or the healthcare professionals at least 6 times, and if we are providing brief advice and registering the patient to the quit lines, it's also present a very important method. So linking the patient for cessation doesn't mean only linking it to tobacco cessation center, but also linking the patient to quit line. Patient may or may not quit at the end of the treatment, but providing that kind of brief advice on multiple times whenever you come in contact with the patient increases the chances of patient quitting the habit. So these are the 5 A's and 5R. Every TB worker, medical officer who is notifying the TB should know these 5 A's and 5R, and basically because the patient is already suffering, and that's the right point, as Dr. Mira also says, we have to know the right point where we have to provide the brief advice, right moment where we have to provide the brief advice, and whenever the patient comes and is diagnosed with TB, which has a lot of stigma, in place when we talk about society. The patient is it's I think it's the right time to tell the patient that it's because of tobacco use that you are currently suffering from a disease which is known as tuberculosis, and then provide the advice, because then the patient ultimately moves to the contemplation stage from the pre-contemplation stage, and is much more receptive towards a brief advice that may be provided to the patient. um, so these are the. So I'll just quickly wrap it up. One more important thing that when we talk about integration need not to happen only at state level, and I think there are responsibility at the national level also. So I think joint framework, I already told you, it is in place. And let me tell you, when we talk about Southeast Asian countries, India is the only country which have this joint TB tobacco collaborative framework. And I think the onus now falls onto the state to address it in a serious manner and implement this, and we will see better TB outcome as well as cessation outcomes in the state. However, I think at national level there is a need to reactivate the integration, and maybe some notification or advisory may be there, so that this TB tobacco collaborative activities comes again into the for the agenda at the state level. So, and plus collective IC and strategic communication campaigns under both the programs can be done at national and state level. One more thing that I already talked about is whenever TB communities are meeting, I think whenever there are TB conferences, I think there should be a dedicated session or dedicated section which talks about TB tobacco also. So I think that will keep the agenda alive, and keep motivating, and keep sensitizing the nodals and TB community that tobacco control is also very important. One more thing is, I think joint capacity building program between NTCP staff and NTEP staff will ensure better, collaboration, better connection of both the programs. And plus, I think we all know that under TB tobacco collaborative framework, there is a bi-directional screening that is being given. So every patient who reports to TCC under NTCP has to be asked about TB symptom complex, and if there are a possibility that the patient reports fever and cough and sweating, night sweats, and all these things, patients should be referred to a TB facility for proper diagnosis. And similarly, whenever a patient comes to a TB facility, patient should be asked for the indicator that we previously talked about, whether the patient used tobacco, what kind of tobacco he uses, and linking the patient to tobacco cessation services. Again and again, I'm telling, because tobacco cessation services in India are not only tobacco cessation centers, they are already existing at national level also. And let me tell you, there are some states which also have considered their mental health helpline or telemanas as to provide a tobacco cessation facility. So patient at the grassroots at that facility sub-center can be referred to a quit line, can be referred to a mental health helpline, and can also be connected to higher centers using e-Sanjeevani. So I think these all are possibility, but ultimately I think one mapping or situation analysis is required in India, because it is almost now 7 to 8 years that we have this TB tobacco collaborative guidelines in place. So I think there is a need for situation analysis and work towards it. So joint monitoring and reporting is very important. Monitoring and reporting should happen at national level as well as state level, and because it can also happen at district level, because I think in Nikshay district level data is also available when we see how many people were asked about tobacco use. And in India, if you ask me, on an average, only 75% of TB patients are asked about tobacco use. And when we talk about tobacco as a major risk factor, it should be almost 100%, so that we don't miss a case, and notify the patient for TB treatment also, and notify the patient for tobacco use also, at least at the state level. So there is a mention of brief advice. So brief advice have multiple models in place, and there is 5 ways also. There is ask advice and refer also. So for NTEP, I think patient the TB workers and medical professional or healthcare professional have some time to spend with the patient. So 5 ways can be practiced. For other complex encounters, where you don't have much time, you can provide a counseling for 3 minutes at least, which is known as ask advise and refer. And also one more thing that I would like to talk about is tobacco free policy at health facility. And let me tell you, making a whenever a patient is coming to a health facility and people are smoking around the patient, again he's more susceptible to having these complex and complicated TB outcomes, because now he's being exposed. And similarly, there is also a concept of smoke free homes. So whenever the patient comes and you tell the patient that you need to comply with the TB treatment, you also tell the patient that you also don't have to smoke, and also people around you within the home should not be smoking, and there should be a smoke free home so that you recover very quickly. With this, I think I've talked about way forwards also. I'll stop, and I don't know if there is a chance of integrating reporting whether the patient was provided brief advice or not. It should be done at the national level, and I think it will really tell us, and it will be a reminder to the person who's filling the TB treatment guide that I have to provide brief advice to that patient, and I have to do 5 ways also. And if the patient is not motivated, I have to do 5 hours. So I'll stop here. Thank you so much, and over to Dr. Rakesh.
Yeah, thank you, Puneet. Dr. Puneet has told us rather briefly about integration of why it is important to integrate NTCP with NTEP at all the levels. And it is very heartening to know that in Southeast Asia countries, only India is doing it practically. And it is a cause of worry that only 32% of TB patients were linked to cessation services. So I think this is important and it is very heartening to know that that is Ayushman Arogya Mandir sub centers, they have started implementing it. So thank you, Dr. Puneet, and can you wait for 2 minutes for any questions? So you have to go at 1:30, no?
Yeah, I can wait for 2 minutes.
Okay.
I have to leave. Yes, thank you.
So if Dr. Rajiv,
Yes,
can
sir.
you ask for any questions?
Yes, sir. So we'll see any question by the participant. In the meantime, I also request all participants to switch on your videos. So I think our team will take a screenshot. And in the meantime, any question by any of the participants, please unmute yourself and ask
So
to expert directly.
Binoy has a question. So Binoy, can you please unmute yourself?
Yes, sir.
Okay.
Yeah, please ask your question, Vinay.
Yeah, thanks to all the resource person for the detailed presentation. It's good to hear that prior to the World TB Day, got a very insights on the issues that is going on at national and state level. So I have two questions, and what strategies we can do to address these challenges. So one question is like, despite the progress, many TB cases remain undiagnosed and, untreated, particularly in rural and hard to reach areas. One is this, and the second one is that TB patients suffer from malnutrition and comorbidities, like diabetes and substance abuse, which can worsen the treatment outcome. So, what should be the strategies, to address these challenges? Because many of the organizations have been working in the at the ground level. So any resource person can address.
So can we direct the questions to Professor Bhardawaj, please?
Yes. Thank you. Thank you for the question. So I will take first the untreated TB patients. So I should tell here that in National TB Prevalence Survey 1921, 63% of Indian, the population, despite having signs and symptoms, do not come forward for diagnosis and treatment of tuberculosis. So either the services are not available nearby or they have a sort of stigma in the community. So recently I was to a tribal area and the situation is worse in tribal area. The facilities available, they're very far off from their place of where they are residing. So we don't have any centers near to their place. So they don't bother to go to the places where services are available, and because they'll also lose the wages. So for those areas, we have to place the services. We have to tap the local agencies so that we can collect samples and deliver the drugs also after diagnosis. So the second is how why we are finding more, not more cases, because asymptomatic TB means latent TB is a concern for our country. 42%. Many people did not agree to it. Then Tamil Nadu government had their own survey and they found 39% of latent TB. So we have to, how to address this latent TB is $1 million question, at least for me. So that is why I was saying in my session that we have to improve the referral from the outdoor and the testing in indoors, the intensified screening in the clinics, whether diabetic clinic, whether smoking cessation clinic. I just agree with the person that bi-directional screening is not there. I will cite the example also of diabetic clinic also. We are screening each and every person who is tested for HIV as well as for diabetes. But on the contrary, in diabetes clinic, if the attendance is 100, not even 20% patients, clients, they are referred for TB screening. We know that diabetes. Same is situation with the smoking cessation clinics. So it has to be both ways. So we have to make people aware of the services. We have to break the stigma. So stigma is so much affecting this TB. People are not coming forward, or people are getting diagnosed in private sector, and they say that we should not be notified and we don't want anything regarding the nutrition. Yes, we in the country, we can do a lot for TB uh, disease, morbidity also, and for mortality also.
Yeah.
Now, what India has done it, the program has done it. They have, from the 1st of November, they have increased the amount to the TB patient from 500 to 1,000, and moreover, they have also decided to provide for 2 months, first 2 months of treatment, the energy rich, the protein rich food to the patients who are malnourished, means the cutoff is who have got the BMI of less than 18.5. So we are doing that. Is again, we the government of India, through the TV, Pradhan Mantri TV Bharat Abhiyan is requesting people to come forward and provide nutritional support to the patient, to adopt the patient, become Nikshay Mitra to the patient, so that you can provide psychosocial and nutritional support to the patient for the duration of treatment. So I have seen many places, many people have taken 10 patients. So we not say take you to adopt 10 patients. Just if you can afford it, take one patient and provide psychosocial and nutritional support to the patient. Without providing nutrition to the patient, the compliance of drug is also less. Compliance that the treatment we are giving it, but nutrition is very important to the patient. That's just. Thank
Yeah.
you.
So thank you, Dr. Bhardawaj. So, I think that answers your question. So, Rajiv, I think
Yes, sir.
Dr. Rakesh Gupta has raised
Yes, sir. Yes, sir. So over to Dr. Rakesh Gupta from Rajasthan Cancer Foundation, sir. Over to you.
Rajiv and Dr. Rakesh ji, very nice presentations and very useful and informative, right from Dr. Ashok ji, Dr. Ravinder, Dr. Puneet. I have question is that if TB was prioritized for elimination way back in 2018, why tobacco was not considered at that time? Because the number of deaths which tobacco causes are almost 9 times more than the deaths which are caused by TB. But yes, I do agree that if we are all on board for TB tobacco elimination, I think the program should be renamed NT2EP. I mean, it may be difficult to pronounce initially, or it can be done something like NT square EP, something kind of, or it should be just National TB Tobacco Elimination Program. It should be renamed. That is what I mean, because tobacco is definitely a bigger priority in a way. And if the Prime Minister, Honourable Prime Minister, is keen to eliminate TB, we all know scientifically that cannot be eliminated until tobacco is also effectively controlled. Its prevalence reduces below 5%, which comes to the end game for tobacco. So I think this is the platform where I think you should send the recommendation that we need to consider both together. That I think will be better. If I have gathered it right, Dr. Ashok ji is the chairman for the NTEP. I think then in that case, I have the right opportunity to convey my feeling that how it can be integrated.
Thank you. Thank you. We'll see to it. We'll see to it.
Thank you, Dr. Rakesh Gupta, sir. So any other question by any of the participants?
So
the
Rajiv, I think
experts?
we are already 6 minutes late, so let us wind
Okay.
up. Okay.
Yes, sir. So, okay, so there is no question now. So I will ask again,
Please
Dr. Rakesh.
acknowledge the people who are here, no? The public health
Yeah, so
specialists.
we have with us, I think,
Stalwarts.
Dr. Mira ma'am, Mr. Abdesh Kumar from Balaji Seva Sansthan, Mamta madam, and Saju Itti from Kerala. So we have many senior experts. So thanks to all for joining us today.
Dr. Siddhi is also with us.
Dr. Siddhi ma'am is also here.
Yeah.
So, yeah, thank you all those who joined. I will ask again Dr. Rakesh Gupta sir from Sipher to say a last thanks to everyone. Over to
So
Dr.
thanks a
Rakesh.
lot, Professor Bhardawaj, Dr. Rana, Singh, Ravinder ji, Dr. Ravinder, Dr. Puneet, and all those who could attend, including the stalwarts like Dr. Mira ji, Dr. Rakesh Gupta from Jaipur, Dr. Siddhi, Dr. Mamta, Avdesh ji, Binoy, Sajueti, and all the participants who could join actually. But I know that some people might have missed it. So we'll be sharing the link to the YouTube recording of this important webinar. So thanks a lot. Thank you. Thank you. Bye. Thank you.